Good afternoon, everyone. So, in today CCR, we will describe a new technique that has been practiced for endoscopic treatment for early GI tumors. So, case will be presented by Dr. Bodhi, and the discussion will be led by Dr. Randeep, and radiological discussion will be done by Dr. Shreya, and pathology discussion will be by Dr. Dipali. Dr. Bodhi, please.
Thank you very much, sir. So, starting with our discussion for today, I am presenting on behalf of Gastroenterology Department, endoscopic resection of GI tumor. So, starting with my patient, he's a 38-year-old male and who was a resident of Delhi, and he had presented to us with history of generalized weakness and fatigue since the last 3 years. However, the patient did not have any respiratory or any cardiac complaints, and patient had required around 8 units of transfusion over the last 3 years. On comorbidities, the patient had a well-controlled diabetes, and patient had a past history of laparoscopic cholecystectomy in 2019 for symptomatic gallstone disease. On clinical evaluation, patient had only pallor, and other systemic examination was non-contributory. So coming to the investigations, the baseline investigation of this patient revealed that the patient had anemia with a hemoglobin of 8.9, and further evaluation revealed that the patient had features of iron deficiency anemia. So we went ahead with an upper GI endoscopy for this patient, and on endoscopy we found out that this patient had a nodular lesion of around 1.5 centimeter involving the first part of the duodenum. And this lesion had overlying central umbilication, and the overlying mucosa was, however, normal. We also subjected this patient to a colonoscopy, which was normal. So, on further evaluation of this patient with a suspicion of duodenal NET because of the endoscopic characteristics, we ordered a few further investigation. Serum chromogranin and serum gastrin level revealed that the chromogranin was 3 times elevated and the gastrin levels was 9 times elevated. And the patient had underwent a biopsy from outside, which revealed that the patient had a well-differentiated neuroendocrine tumor of grade 1 with a Ki67 index of 2%. A Dodonov PET scan had also been done, which revealed that there was a focal increase in the somatostatin receptor expression involving the D1 segment of the duodenum, and however the PET did not reveal any other areas of uptake. So now I will invite my colleague Dr. Shreya Gulati from the Department of Radiology to discuss the radiological imaging features of this patient.
Good afternoon, everyone. So, since we knew that we were looking for a neuroendocrine tumor in this patient, we went ahead with a dual phase CT for this patient, including an early arterial phase as well as a venous phase. So, on the arterial phase images, we saw that there was a very small 1 centimeter hyperenhancing lesion in the first part of the duodenum along the lateral wall, which is as depicted by these arrows. On the venous phase, the lesion was not well appreciated, so likely washout. So based on these findings were consistent with the possibility of a neuroendocrine tumor.
Thank you, Dr. Bodhi and Dr. Shreya. So with the known diagnosis of duodenal neuroendocrine tumor here, we went ahead with endoscopic full thickness resection, which was done under general anesthesia, and the specimen was sent for histopathological confirmation. There were no post-procedural complications. This is the image prior to the endoscopic full thickness resection. So with the technique of endoscopic full thickness resection using full thickness resection device, post resection we can see the closure device and its clamps which are seen surrounding the resected area. This is the resected specimen showing showing grossly all the 4 layers of the duodenal area. So the videography of the methodology. So first off, we did the marking of the lesion so that at the time of application of the device, we have a better marking available. The device, this is the full thickness resection device. The lesion was sucked inside the cap and the closure device was applied. Post resection, this is the area which can be seen on the video recording done. I would request Dr. Dipali from the Department of Pathology to share the histopathological findings.
Good afternoon, everyone. We received a full thickness resection of the duodenal lesion, which showed us a circumscribed 1.3 centimeter tumor, which was predominantly in the lamina propria, and it was pushing against the mucosa, but the mucosa was normal. The tumor was arranged in organite and trabecular architecture, composed of monotonous round cells with scant cytoplasm and stippled chromatin. The tumor cells were immunopositive for chromogranin and synaptophysin and showed focal patchy positivity for gastrin. Ki67 labeling index was around 2%. So on the histomorphology, immunohistochemistry, and Ki67 labeling index, we came to diagnose a well-differentiated neuroendocrine tumor of the duodenum, WHO grade 1 and pathological stage of T2.
Coming to the discussion part. So overall, whenever we find an upper GI duodenal polyp on upper GI endoscopy, the currently available data shows that any duodenal polyp has a prevalence of around 1 to 5%. Most common lesions found on as a duodenal polyp can be a lipoma, GIST, carcinoid, that is neuroendocrine tumor, hematoma, Peutz-Jeghers polyp, or an adenoma. These lesions can be subepithelial or mucosal. Most of the lesions do require resection as they carry malignant potential, but lipoma and a hematoma can be left as such if they are not symptomatic. For duodenal neuroendocrine tumor, they have an overall incidence of 1.9 per million. Out of all the primary duodenal tumors, they constitute 1 to 3% and are located mostly in the first and the second part of duodenum. On upper GI endoscopy, most of this particular lesion is smaller than 2 centimeter in size. As the size increases and the grade of the tumor increases, they have a high chance of metastasis, carrying an overall incidence of 40 to 60% chance of lymph nodal metastasis and around 10% chance of liver metastasis. According to this large series of 927 patients of duodenal neuroendocrine tumors, most of the duodenal neuroendocrine tumors are non-functional, that is around 90%. 10% of the duodenal entities can present as a gastrinoma, and 4% of the duodenal entities can present as carcinoid syndrome. Most of these patients are asymptomatic and are found incidentally on upper GI endoscopy, but close to 1/3 of these patients can have non-specific symptoms of abdominal discomfort and pain. And also around 1/5 of the patients can have either bleeding or anemia at the time of presentation. Histological grading is followed as provided by WHO. These tumors are divided into 3 grades, grade 1, 2, and 3, according to the histopathological features of mitotic index and Ki67 proliferation. The grade 3 tumor, which has a high risk of high malignant potential and high risk of metastasis, is also called as neuroendocrine carcinoma. Overall, for the evaluation of duodenal NAT, an upper GI endoscopy is must, and initial biopsy is required for the confirmation. These lesions present as nodules mostly, and they have a central implication as the size increases, which otherwise signifies that the invasiveness of the lesion increases. For a lesion more than 1 centimeter of size, they should undergo an EUS evaluation for identifying any submucosal invasion. And imaging like CCT and CMRI are required for better localization for other lesions and for metastatic lesions associated with the primary lesion. If there is a low-grade tumor, the functional studies like Dotanok PET are found to be useful for better anatomical localization and metastasis as well. And as a contributory, as a part of evaluation, biochemical markers like 5-hydroxyindole acetic acid and chromogranin A are available currently, but they have a poor sensitivity and specificity. Currently, according to the available data, ENETs suggest that any duodenal NAT which is lesser than 5 millimeter of size can undergo an endoscopic resection, or we can wait and watch if the lesion does not have any high risk pathological features. And if there is R1 resection on after the endoscopic resection, an annual endoscopy is indicated and surgery is indicated if there is any recurrence. For any lesion of 5 to 10 mm, an EUS evaluation is required. And in a low-grade lesion and a non-invasive lesion, endoscopic resection is indicated in the form of endoscopic mucosal resection and endoscopic submucosal dissection. But if the features are of a high-grade tumor or a metastatic lesion, surgery is indicated. And any lesion more than 1 centimeter should currently undergo a surgical resection. So currently available endoscopic modalities for early GI tumors, we have endoscopic mucosal resection, which is usually useful for any lesion less than 1 centimeter, in which we inject saline in the submucosal plane and after localizing the mucosal lesion and resect using a routine polypectomy snare. Endoscopic submucosal dissection is better modality for any lesion which is more than 1 centimeter in size and provides better en bloc resection. In this, we mark the lesion using electrocautery, and after submucosal injection of the saline, we dissect the planes in the submucosa, and submucosal dissection is done and en bloc resection of the lesion is taken out. But this modality is difficult to practice in a duodenal lesion, considering thin wall of the duodenum. There is a high risk of perforation when this modality is applied for duodenal lesions, and in general NATs are submucosal lesions and they are associated with a lot of fibrosis, so endoscopic submucosal dissection gets difficult with these lesions. So for this, an upcoming modality of endoscopic full thickness resection is right now applied and is being practiced. This is one example of endoscopic submucosal dissection done for a rectal laterally spreading tumor. We can see after marking the lesion with an electrocautery, the submucosal, this is the submucosal plane after dissecting out the lesion, and later on the normal mucosa can be seen separated from the area where the lesion was placed earlier. So coming to the endoscopic full thickness resection using a full thickness resection device. This device basically is applied over the scope. We can see this cap over which the closure device is attached. This closure device has a string attached to it which is taken out through the scope, the channel of the scope, and is attached to this applicator handle. And also this device has a snare which is used to resect and cut the lesion, which is applied to this electrocautery, which is then attached to this electrocautery device. So in this technique per se, through the scope, we use a grasper forceps to take hold of the lesion and pull the lesion through the cap, and using the suction, we suck in the lesion, and all the layers of the intestinal wall are sucked into the cap, and after that we apply the closure device before resecting out the lesion, and then the lesion is resected out using an electrocautery snare. So this is the largest series of duodenal lesions which have been taken care using an full thickness resection device, out of which most of the lesions were duodenal adenoma. The technical success of this device application and resection was to the tunes of 85%, and R0 resection was achieved in 63% of the cases. Also, the endoscopic full thickness resection done for any upper GI lesion involving esophagus, stomach, or duodenal lesions. Overall, the technical success was found to a tune of around 83%, and R0 resection has been achieved in 70%, and minor adverse events to the tune of around 19% have been seen, which have been managed endoscopically mostly. So in this index case, on following up, currently the patient is asymptomatic. He tells improvement in his weakness and fatigue, and he has not required any further need of transfusion. So summarizing, duodenal lesions can be of various types. Neuroendocrine tumors form a good number and are predominantly localized in the D1, D2 area of the duodenum, which can be taken care of endoscopically in case endoscopically resectable. Endoscopic techniques for removal of duodenal lesions. For smaller lesions, endoscopic mucosal resection can be done, or endoscopic submucosal dissection can be done. Endoscopic full thickness resection using full thickness resection device provides a better R0 resection and can be applied for any lesion more than 1 centimeter, even those with submucosal invasion. Thank you.
Thank you, Randeep. So we discussed this case because there are various ways to remove the early GI tumors, which is usually T1A lesions. So what are the techniques like endoscopic mucosal dissections and submucosal dissection, in which we go into the plane between mucosa and muscle layer, that is submucosal layer, by injecting saline or hyaluronic acids, and then we separate the tumor from the normal muscle layers. But what happens when there is a submucosal invasion? Then it becomes very difficult to do EST because it leads to the further bleeding and also the perforation rate is higher. But if it is a smaller lesion and submucosal invasion, then EST is usually not possible. Then we can apply this new technique, that is endoscopic full thickness resection. This is device. There is other ways to do the endoscopic full thickness resection. So this is very easy device, but it is costly, around 1.5 lakh rupees it cost. But it can be easily done, and R0 resection is very good, and in toto that includes both muscle layer that can be taken out. So R0 resection and depth of invasion that can be taken. Sorry, sir? Yeah, sir. So, but for this small lesion, if you will do the surgery, that is more morbid. Reason being that duodenal entities are having higher chance of metastasis as compared to the gastric neck. So that's the reason we require removal of most of the duodenal entities. Any question is welcome.
What happened to the gastric level? So that is a tumor mark.
Yes, sir.
You had a 9 times, 10 times increased gastric level.
Yeah.
It is saying origin in medicine.
So,
the gastric level, by the time you take it out, you already metastatic.
so on both the imaging CT scan and
Imaging biochemical marker.
biochemical, we have not repeated right now, and patient was on PPI at that time. So.
उसके बाद अभी पेशेंट का रिपीट जो है 110 आ गया है.
Okay.
Patient is from Bombay. Patient came from Bombay. उसको repeat हो गया.
Imaging in such small tumor, they have got a physical limit. They can
Yes.
do that. Again, second question: is 70% R0 dissection acceptable to the surgeons?
So,
To the patient?
so sir, this
Because
is
such a small tumor, you expect that only 95, 98% surgery. For a T1A tumor, it will say R0 dissection is 70%. Is it acceptable to surgeons?
So issue that is every duodenal lesion, duodenal net will progress to the neuroendocrine carcinoma. It's not true.
But are these
Yeah, it's not true. Also, for a small lesion, doing a surgery, in duodenal surgery, is more morbid. Those who are having posterior wall, or it is very difficult to do. So that's the new technique is upcoming, so that we can endoscopically we can take out. ESD can be done, and for not NET, for other duodenal superficial tumors, the ESD is very successful. The only problem is that because of thin wall, the perforation rate is very high during the procedure. However, most of the time it is being taken endoscopically. And also the duodenum is more difficult location to do ESD as compared to the gastric or esophageal or colon lesion because of the position of the scope and the duodenal contours. Sorry? Yeah, that's what I'm saying.
Yeah.
Possibly you can do because there is supporting tissue there. Duodenum is a retrograde structure. On the anterior side, there is liver.
Yeah.
Posterior side, there is retrograde.
So what happens when you are doing colonic ESD and gastric ESD, even there is a small muscle perforation, you can close it very easily. But in duodenum particularly, what happens, if there is a perforation, you have to completely close it, and that by the various methods. That's the, problem with the duodenum.
How do you propose to keep this patient on follow-up? What sort of follow-up will you keep with this patient?
So, for any early GI tumor, because of recurrence rate differs when you do ESD, if it is complete R0 resections, then usually 1 year endoscopic follow required because of two reasons. One is recurrence. Yes. So one is R0 resection, and second is the metachronous lesion. The second possibility is metachronous. The second problem is that the depth of invasion. If the depth of invasion in submucosa from S1 to S3, like first part of submucosa, second part of submucosa, and third deeper layer of mucosa, as the invasion increases, you do ESD, the chances of having metastasis and recurrence increases. So on that basis, so the ESD pathology, histopathology is completely different from the normal biopsy what we do. Because in ESD pathology, they have to report R0 and also the depth of invasion has to be reported.
So what should have mentioned in those here?
So because what is the alternative? Let's say this patient would not have undergone this procedure.
So surgery can be done and ESD can be done. And also the nuclear medicine treatment that can be.
What surgery would be done?
There's too early disease for nuclear.
Yes.
This is the
No, if sir metastasis, sir.
What would you require? Ripples? Or what would you do?
the surgery. What can we can remove the tumor alone? You probably can be closed. 1.2 centimeters. I think you are not there.
So 1.2 if it is towards the pancreas, then obviously it will.
So let's say
But if it is on the rectal wall, here,
medial wall पे
medial wall of what pancreas.
But let's say, okay, let's for the case scenario, let's say it was 5 centimeters inferior, 3 centimeters inferior. Then you would have to look most likely because it's a huge surgery compared to this kind of procedure where the patient is sent home within a day. That is the whole purpose of this.
So other way of doing is the combined surgery. You do endoscopic resection and close with laparoscopic technique.
We also can do the same thing. We can open the duodenum and do exactly the same thing that we have done.
So you should have started it earlier.
So hybrid technique is also described. You can do endoscopically and close laparoscopically if it is larger defect.
The physicians are becoming aggressive surgeons.
We are following intervention.
Nobody took either the cardiologist or the stabber. Last government replacing the valve, replacing. So similarly, physicians are becoming more aggressive and the line is becoming broad, more aggressive physicians for all this.
So the other reason is technical advancement. That's the reason that minimally invasive surgery or endoscopic technique is coming in at that way, sir.
In the next week, I will be presenting endoscopic gastroenterology and hepatitis.
So endoscopic gastroenterology is being done very frequently nowadays.
For palliation endoscopy, gastroenterology and hepatitis.
Mm.
No, no, वो ठीक है, that means that when gastroenterologist will present research, that means that
No, but they are already in the endoscopic gastroenterology.
they can do through the open their own night, they can use through the instrument verify. When the gastroenterologist will do diagnosis through the
The gastro is good.
gastrology.
Yeah.
So you can present that.
So endoscopic gastroenterology is being done, not hepatococcygestomy. Thank you. So hepatogastroscopy we do for biliary drainage. Thank you. Thank you.
Good afternoon. I know most of these cases they have done, and it's a tremendous job. And they have, in fact, helped us in managing this case, a lot, guide us for what to do. This is a case of advanced pancreatic cancer, otherwise deemed to be unresectable, and leave the patient as such to the fate. But somehow we could manage this. So this is the story of the case. Sampa. Just a brief description of the anatomy. The pancreas is mostly in the pancreatico-duodenal complex, and the head of the pancreas and neck of the pancreas remains inside the duodenum. The common bile duct and the pancreatic duct, they open into the duodenum second part. And there is a complex arteriovenous arcade here supplying the pancreas, ultimately draining into the portal vein, which also drains blood from the entire bowel to the liver. And along with that is the superior mesenteric artery, which supplies the small bowel in entirety and part of the large bowel, and no other vessel. So these two, they traverse behind the neck of the pancreas and go towards, one goes to aorta, one goes to the liver. If we remove the pancreas and the duodenum, this is how the picture is, means these two remain behind the course along the posterior part of the pancreas. The pancreatic cancer, actually popularly known as pancreatic adenocarcinoma, there are many malignant tumors of the pancreas, and commonest site is the head. If it is less than, it is said that it is less than 5 centimeter maximum, and it is not involving in any of the major vessels, these two mostly, then we can resect, and that is the best management for a pancreatic cancer. If untreated, the median survival is 20 months. Depending upon the resectability of the pancreas, pancreatic cancer, it has been divided into 4 types, or rather 3 types. The borderline resectable is the tumor which is involving the portal vein and not going towards the SMA. The arterial resections, management of the artery is actually very, very unsatisfactory in GI surgery experience. So if it involves the portal vein, the resection and management has a good result, as good as the resectable malignancies. But if untreated, median survival 12 months. Then comes the locally advanced one, when the tumor crosses the portal vein and goes to the superior mesenteric artery, either to the periarterial tissue, the lymphatic and nervous tissue, or the SMA proper. So this becomes problematic in the management, and the management differs. Mostly the reports are anecdotal what to do. And the fourth one is unresectable as well as metastatic one, which you can't do anything, and the survival drops to 4 months. So with chemotherapy, the lifespan is increased by 3 months with a better quality of life. And especially we have selected this one, to which our case belongs to this category, and how we manage with a lot of difficulties. That is how the case is to be. So I invite Dr. Siva, our senior resident and senior MCH, will take you through the case history along with our other colleagues who have taken part in the management.
Thank you, sir. Our patient is a case of locally advanced pancreatic cancer. According to the guidelines, the primary goal of treating these patients is palliation and lengthen survival. In addition to that, if the patient has a reasonable performance status, if it is good, the patient can undergo chemotherapy, which is mostly an oxaliplatin-based FOLFIRINOX chemotherapy, or it can be a gemcitabine-based nab-paclitaxel-based chemotherapy. After receiving chemotherapy, 15 to 22% are successfully downstage to a resectable disease. And if these patients undergo surgery, their survival is equal to those who are initially determined to be resectable. Coming to the case history, our patient is a 55-year-old lady from Delhi who presented with an 8-month history of pain upper abdomen, which was radiating to the back. There was associated loss of appetite and loss of weight. She was a diabetic for the past 4 years on oral hypoglycemic agents. On examination, she had a good performance status. Vitals were stable. BMI was 21. She was not pale or icteric, no bleeding, edema, supraclavicular node. Per abdomen examination yielded an 8 into 8 centimeter hard lump, which was fixed, hard, non-tender, and it was not mobile. Per rectal examination was normal. Just the normal breath and heart sounds were present, no added sounds. So the provisional diagnosis is a malignant neoplasm, which is arising probably from the pancreas. The basic investigations, hemogram, renal function test, and liver function tests were all normal. She was a diabetic, initially out of control. HbA1c was 8.6. When it comes to the tumor markers for the pancreas, CA19-9 was more than 1000, which itself indicated advanced nature of the disease. I now invite Dr. Rhea to come and describe the CE-MRI, which was the pre-neoadjuvant chemotherapy image.
Good afternoon, everyone. So a CE MRI was done for this patient. On the T2 weighted images, we can see that there is a large 9 into 7 into 9 centimeter heterogeneously T2 hyperintense lesion, which was showing these hypointense septae within. These septations were showing areas of diffusion restriction within. On the MRCP images, we can see that this lesion was communicating with a dilated MPD, which is also seen on the previous scan here. So these are the contrast enhanced MR images for this patient, and we could see that this lesion was showing progressive areas of nodular and thick septal enhancement within this lesion. The locus spread, the lesion was infiltrating anteriorly into the wall of the stomach, the first part of duodenum, the second part of duodenum, and there was large area of contact and luminal deformation involving the main portal vein, the portosplenic confluence. And on the arterial face images, we could also see that the SMA was abutted anteriorly by this lesion. So based on these findings, we kept a possibility of a CA head of pancreas developing in a background of main duct IPMN because of the dilated MPD.
The patient next underwent an endoscopic ultrasound and biopsy from the head of the lesion. This is pancreatic mass. The echoendoscope has been passed and multiple passes are made using the fine needle into the pancreatic mass. So I now invite Dr. Dipali to shed light on the biopsy from the mass.
Good afternoon, everyone. So we received a biopsy from the mass in the head of the pancreas. No normal pancreatic tissue was identified, and we see tumor cells arranged in back-to-back glandular pattern along with pools of extracellular mucin. So diagnosis of mucinous adenocarcinoma was considered.
Our final diagnosis was a carcinoma from the head of pancreas, a large lesion, and it was locally advanced. There was definite SMV and portal vein involvement with the very doubtful SMA involvement was there. It was a poorly differentiated mucin secreting type. All these are unfavorable factors. In this picture, you can see that this is the mass which is involving the entire pancreas, the head, body, and only very little of the tail, less than 1 centimeter of the tail was left, and this is the spleen. This mass involves the entire pancreas, the common bile duct, and it also involves the portal vein, which is here. So our primary plan was to give her a neoadjuvant chemotherapy, FOLFIRINOX, and reassess the patient. If her functional status is good and if the tumor turns out to be resectable, then we will proceed with the surgery in the form of extended pancreaticoduodenectomy. So accordingly, this patient received neoadjuvant chemotherapy, FOLFIRINOX. The last cycle was in June 2022. And after receiving chemotherapy, the patient was reassessed. As you can see, the hemogram, LFT and RFT values were normal, but the tumor markers did not improve. CA99 increased from more than 1000 and it became more than 1200. For discussing the post-chemotherapy images, I invite you on.
So another MR was done for this patient following neoadjuvant chemotherapy, and we can see pre and post chemotherapy images. There was no significant interval change in the size and extent of the mass. So this patient was then planned for surgery, and preoperative CT was done for planning for surgery. Again, we can see this large mass lesion epicentered in the head and the proximal body of the pancreas, which was infiltrating into the stomach, the first part of duodenum. The distal pancreas is atrophied, and the dilated MPD is seen to communicate with the lesion. With respect to the vascular, there is a large area of deformation and luminal narrowing involving the the main portal vein, the portosplenic confluence, and the SMV. The SMA, again, we can see is closely abutted by the lesion. So summarizing my findings, there was a large pancreatic head mass which was communicating with the dilated MPD with atrophy of the distal pancreas. It was infiltrating into the antrum, the first and the second part of the duodenum. There was distortion and luminal narrowing of the SMV, the portal vein, and the portosplenic confluence by the mass for a length of 7 centimeters. The GDA, which was seen directly arising from the celiac artery, was encased by the mass, and the splenic artery was also encased by the mass. The SMA was anteriorly abutted. The celiac artery was free, and there were no liver metastases. So for planning for surgery, there was some relevant vascular anatomy regarding this patient. So there was a replaced right hepatic artery which was arising directly from the SMA, and also a replaced left hepatic artery arising from the left gastric artery.
Can you just show the pre and post MRs again?
Yes.
It looks distinctly lighter. Does that mean anything?
No, sir, that's just the image acquisition.
Black and white. You can see in that image a little bit.
Okay, thank you.
Regarding plan for the course, we planned for surgery, but she was lost to follow up for a month, and she consulted multiple centers where everybody denied any form of intervention. Because of intractable pain, she came back fully motivated for treatment here, and the plan was an attempted resection under extreme high risk. The purpose was to palliate her pain, and over and above that, a bonus, an attempted curative resection. The difficulty which was anticipated was portal hypertension and the presence of collateral. This was because she had an obstructed portal vein for a time of almost 8 to 10 months. There could be major vascular resections and possible multivascular resections also. And the final surgical plan was resection of the tumor with resection of the SMV and the portal vein, and if required, the SMA with reconstruction with graft. We decided to undertake the resection in the CTBS OT under the cover of Professor A.K. Bissoy for any vascular emergencies. These are the steps of the surgery. Initially, a small incision is made in the right subcostal region to assess for any metastasis. There were no metastases. So it was converted into a full incision. This is the bilateral subcostal incision. One of the major findings that we saw was the presence of huge collaterals. These collaterals were in the superficial layer, they were located in the greater omentum, and beneath that, they were located in the retroduodenal area, which is the area of our dissection or for Whipple's. And there was a huge mass. Upon opening the lesser sac and reflecting the stomach up, this is the stomach which is being reflected up, and the colon down, we noticed that there is a huge mass which is replacing the head of pancreas, the body of pancreas, and the tail was almost not seen. It was very atrophic. An intraoperative ultrasound was done and the findings were confirmed. The portal vein infiltration was confirmed, but regarding the artery, we couldn't make out whether the artery is frankly infiltrated or only the peri-adventitial tissue is involved. So the above three pictures, these three are steps of a standard Whipple's procedure. In this you can see that the colon is gradually reflected away from the tumor. The tumor comes into view here. And then we divide the stomach. The common bile duct is also divided here. The neck of the pancreas is divided, and all the dissection is carried out only to the right of the portal vein. Whereas our resection is a little bit different. We saw huge collaterals and we wanted to decompress the collaterals. So what we did was, with the tumor in situ, before the resection itself, we did a bypass from the SMV to the portal vein. And instead of resecting only the head of pancreas, since only the tail is remaining and the tail was also atrophic, we decided to go ahead with the total pancreatectomy. So this is the dissection around the spleen. Now to tackle the collaterals, we did a bypass. This is a bypass graft rising from the SMB and going all the way to the portal vein with the tumor in situ. This is the intraop picture. You can see the tumor here under the fingers of the surgeon. This is the graft. This is the SMB here. And the graft is going all the way to the portal vein. So after establishment of this bypass, we gave an interval of 1.5 to 2 hours for the pressure in the portal system to gradually come down so that the blood loss can be reduced greatly. To tackle the artery, we did what is called as periarterial clearance. The term for this is periarterial divestment. Divestment is a term which is not a medical term, it is a business term which has come into medicine. It means we do away with all the subsidiary and additional businesses. So like that, here around the artery, around the superior mesenteric artery, we have a lot of neurolymphatic tissues which are taken out. So this is called periarterial divestment. The above three pictures are from an anecdotal case, which is similar to our case. You can see that this arrow mark here is where the superior mesenteric artery is. It is completely buried by the tumor. Gradually, the dissection is carried out around the superior mesenteric artery. And here you can see that the superior mesenteric artery is fully bare. Here for the portal vein, they have done they have put in a graft which is similar to our case. And this picture you see is a standard Whipple's procedure, where this is the superior mesenteric vein, this is the portal vein here, this is the IVC, and you cannot see much of the SMA. The SMA is somewhere here. It is buried, it is deeper and to the left of the portal vein. And usually we don't do any dissection around the superior mesenteric artery in the standard Whipple's procedure. But what we have done, this is our intraop picture, where we have proceeded from the left side, from the splenic side. We came first, this is the artery, and completely all the neurolymphatic tissues around the artery is cleared, and the specimen is finally taken out. The tumor will finally be here and it will be taken out, and already the portal vein graft is in situ. So resection is almost done. And this right angle is hooking around the replaced right hepatic artery. As we saw in imaging, there was a replaced right hepatic artery which is arising from the superior mesenteric artery here. So this is something that additionally we had to do. We had to clear all the periarterial clearance has to be done even in the root of the replaced right hepatic artery. This is a video which demonstrates the standard Whipple. This is the cut end of the pancreas. You can see the pancreatic duct here. This is the superior mesenteric vein, the portal vein, and this patient also had a replaced right hepatic artery. This is the cut end of the common hepatic duct. This is the cut surface of the pancreas, and this is the pancreatic duct, which is well seen here. This is a standard Whipple's procedure. So coming to our case, we had three problems with the field of surgery. One is there was diffuse fibrosis around a huge tumor, and the patient had undergone chemotherapy. Second, there was the presence of huge collaterals. So we had to decompress these collaterals. This is the huge collateral sitting on the tumor, in the paraduodenal area. And finally, the forceps is pointing to the place where the portal vein is coursing through the tumor. Finally, after the resection has been done, this is the cut end of the jejunum. This is the cut end of the stomach. The lie of the bowel is good for doing a gastrojejunectomy and hepatocojejunectomy. You can see the pulsations of the SMA. It has been bad all around, all 360 degrees. The neurolymphatic tissue has been removed. And this is the bypass, which is taking off from the SMV here, all the way to the portal vein above. And finally, this is the final specimen. This is a standard specimen where only the pancreatic head is present in the C loop of the duodenum, and this is the distal stomach. This is our specimen where it includes the entire pancreas with the spleen, a huge mass. This is the stomach side and the great lumen. And then we proceed to reconstruction. This part of the reconstruction, which is usually done is between the pancreas and the jejunum, we did not do because we had removed the entire pancreas. Pancreaticojejunostomy was not done in this case. We directly proceeded to the hepaticojejunostomy. This is the cut end of the common hepatic duct, and this is the jejunum. This is the intra picture. Second was anastomosing the cut end of the stomach with the jejunum, which is the gastrojejunectomy. And additionally, in this case, we had done a side-to-side jejunojejunostomy. This was for bile diversion. Bile will come from here, and instead of reflexing onto the stomach, it will come straight into the jejunum. Drains were inserted, and the abdomen was closed. Postoperatively, this patient was shifted to the ICU. She was shifted intubated and on low dose inotropic support. On postoperative day 2, she was extubated and ecosprin was started. Insulin infusion was going on at that time, and Doppler was done in POD 1 and POD 2, and that showed a normal portal flow. There are normal flow in the portal vein and also in the hepatic artery. On postoperative day 3, an esojejunal trial was tolerated, and oral CIPS was also started simultaneously. Her noradrenaline had been stopped by then. Again, a Doppler yielded normal portal flow. Insulin infusion was in the range of 33 to 46 international units, and blood sugar was 140 to 340 milligram percentage. On postoperative day 6, she was fully orally allowed, and fixed dose insulin was made. It was 35 units per day. The drains were subsequently removed on POD 7 and 8, and she was discharged on POD 12 on fixed dose insulin. Coming to the final histopathology.
We received a specimen of pancreatic or duodenectomy with the spleen and gallbladder retroportal lymph node and the omentum sent separately. So we saw a large solid cystic tumor which was replacing the entire pancreas. It was ulcerating the duodenum, ulcerating the mucosa of the duodenum. The tumor showed pools of extracellular mucin, and as said previously, it was an adenocarcinoma, and it was transmurally infiltrating through the duodenum and ulcerating the overlying mucosa. Lymphovascular invasion and perineural invasion was seen. There were 2 lymph nodes that showed metastatic tumor deposit. All surgical margins were negative. Mucinous adenocarcinoma with the pathological stage post-therapy was T3, stage group was 2B.
This patient is under regular follow-up. Last telephonic follow-up showed that she was on full orals and back to routine activities. She had no pain. She was only on ecosprin. And again, her hemogram, RFT, and LFT were normal. CA99 had come to the hundreds range. From thousands, it had reduced to the hundreds range, and others were within normal limits. Ultrasound and Doppler, which are the latest imaging that she had, showed no abnormalities, and there was no evidence of any recurrence. Now, in Whipple's procedure, when it comes to extreme resections became commonplace in the last decade, where it can be done with regards to the vein, it can be done with regards to the artery. The third technique is very new, first came up only in 2016, which is called as periarterial divestment, which is clearance of the tissues around the arteries. Venous resections are done very commonly. In our institute, the incidence of venous resections that we do is almost 4 to 5%. It can be done in the following ways. When only the sleeve of the vein needs to be removed, primary anastomosis can be done here. Provided there is no stenosis at this level, you can do an anastomosis, you can primarily suture the vein shut here, and that is the first type. The second one, if there is going to be any doubt of stenosis here, we put in a patch and sew the patch inside the vein. This is type 2. Type 3, when we resect the entire vein and it can be anastomosed without tension, that is type 3. See the corresponding picture here. And when there is going to be any doubt of tension at these two ends, we put in an interposition graft. The survival after venous resections, after procedures which involve venous resections, is equal to the standard Whipple's procedure, which does not involve venous resections. And it is very, intervention in the form of venous resection and reconstruction is very well established now. Same cannot be told about arterial resection. This is a meta-analysis where they have reviewed 263 patients who underwent some form of reconstruction in the artery. Among these 263, hardly 60 were interventions on the superior mesenteric artery. And all of them, the report is, the result of the surgery is not very good. In this picture, you can see that the portal vein has been resected and end-to-end anastomosis has been made here. Also, if you can see here, this is the superior mesenteric artery, where a segment of the artery has been excised and end-to-end anastomosis has been made. The third procedure that we want to put forward is the arterial divestment, which is, here you can see that this is the pancreas with the uncinate process. These cancers have high rate of perineural invasion and lymphovascular invasion. So all the tumor cells will go via these channels and they will be running around the superior mesenteric artery. So in periarterial divestment, what we do, instead of resecting and anastomosing and resecting and reconstructing the artery, whose result is not very good, we only clear the neurolymphatic tissue around the superior mesenteric artery. This is our picture again, which shows that all 360 degrees around the SMA, the tissue has been cleared. Already the bypass graft has been put inside. So this is a case series from Limbu et al., which shows that among 7 cases, the operating time was of patients for whom periarterial divestment has been done is almost equal to a standard Whipple's procedure, and blood loss is not that high. In our case, it was 8 hours and 1500 ml blood loss was there because it involved other procedures. We had to do a bypass, and after the bypass, we had to wait for 1.5 to 2 hours for the portal pressures to come down. So we had a increased operation time, and expected blood loss was also a little bit higher than the usual standard Whipple's procedure. Comparing arterial resection, periarterial divestment, and our procedures, we see arterial resections here. The time duration is very high, almost 12 to 14 hours for a single Whipple's procedure. The blood loss is in the range of 6 to 8 liters, and the in-hospital mortality can be as high as 20%. But the patient ultimately they survive only for 11 months. Whereas in periarterial divestment, the result is good. The duration is a little bit higher than the usual Whipple's procedure time, so 6 to 8 hours. Blood loss is in the range of 2 to 3 liters. In-hospital mortality is acceptable at less than 5, and median survival they achieve of almost 40 months. Our case, the time duration of surgery was 8 hours, blood loss was 1500 ml. She is still surviving 18 months post surgery. After any Whipples, after the standard Whipples, we expect complications like bleeding from the arterial stumps. We expect a leak from the pancreatic stump. The remaining pancreas can go in for inflammation, stump pancreatitis, and delayed gastric emptying as well. Related to vascular resection, there can be stenosis. This stenosis can be extrinsic. If there's going to be a collection in the abdomen, ascites, or leak, localized collection can compress on the vein and cause extrinsic stenosis. There's going to be tension in the anastomosis, and the stricture of the anastomosis, that is called intrinsic stenosis. The reconstructed part can go in for thrombosis, and the ends of the reconstruction can also have pseudoaneurysm. One very peculiar complication which is related to the periarterial clearance, periarterial divestment, is the presence of diarrhea, whose incidence is almost 60%, and this is mainly due to the loss of mesenteric arterial neural plexus. Our patient also had diarrhea and weight loss also post surgery, but it settled on its own after. To summarize, the locally advanced carcinoma of the pancreas has very limited treatment options. After giving neoadjuvant chemotherapy, only 15 to 20% becomes candidates for chemotherapy, and that too when they have a good functional status. Surgery will usually involve complex vascular resections. Our case, we had we did not have much of favorable factors. It was a huge tumor. It was a long venous involvement was there, necessitating definite venous resection and reconstruction. And the need for periarterial involvement was there. So we had to tackle the artery also. And over and above that, the portal vein was obstructed for a very long time, leading to huge venous collaterals. And there was massive risk of bleeding. The innovation that we put forth is that we dealt with collaterals with the venous bypass at the initiation of surgery. So that reduced blood loss a lot. And in the same stage, we did tumor clearance also. So the topic for today is pushing the limit in pancreatic cancer surgery. So we tell that prescribed limit of pancreatic cancer surgery can be stretched to give the patient a pain-free quality of life and acceptable surgery. That is our message for today. Thank you.
So there was a concern regarding post surgery resection of the planes. So it is said that the post chemotherapy, the planes are better delineated than in 8 cases.
So it was not appearing like that in the imaging. So intraoperative ultrasound, they said there is a possibility that it could be just limiting to the tunica adventitia, but definitely they said there was no infiltration. We are not sure whether actually that was because of the neoadjuvant therapy or not. It's difficult to say, but the imaging was same. Here actually the periarterial divestment not only includes the nerves and the lymphatics, you have to take out the adventitia also. That is where the problem lies, the risk of pseudoaneurysm injuries. The SMA resection and anastomosis, the bowel is only maximum survives ischemia for 20 minutes. 20 minutes only. So if you are unable to do resection anastomosis of the SMA in this period of time, then you have a very, very bad result. And everybody has a bad result. So this divestment technique has come up, and you have to really dig in from other side to clear the SMA which lies hidden inside. So this is the first time that we combine the divestment along with the portal vein resection and anastomosis.
Very nice case, sir. Sir, had there not been a replaced right hepatic artery and a left hepatic artery, because the GDA was already involved, would the dissection have been more difficult? Or?
Yes, you're correct. So actually that was a God gift for us that the hepatic artery was arising from the SMA. So we could guide ourselves from the SMA through that. In the past, we have done, we recently did a hepatic artery involvement. So we had to resect and put a graft along with that. So that has to be added to that. That comes with the definition of borderline pancreatic cancer. Then hepatic artery is not a problem because the liver can sustain ischemia for quite a long time. And plus portal vein is there. So we have done a case wherein we have to dissect the portal vein and the hepatic artery in a hurry. It's a big tumor in a case of extrahepatic portal venous obstruction with collaterals. So while doing that was the first case we are doing. So while doing the case started bleeding. So in a panicky, whatever came on the way, we cut it. And then finally reconstructed everything. We reconstructed the hepatic artery by using a medial colic. That's a new innovation.
Was the normal pancreas, the spared part of the pancreas, was it showing changes of IPMN or pathology? Very odd tumor. Morphology of the tumor is not like the common garden variety of PDAC. Usually PDAC don't achieve this size only.
Yes.
You don't see this kind of morphology. So was it a tumor arising in background of IPMN?
Honestly, the pathologist will be able to tell that. But imaging wise, they were saying it was possibly a background of IPMN. See, it was the mucin secreting, it was the poorly differentiated carcinoma. In spite of all this could be managed. That is the. So, 18 months she is doing well, and otherwise lifespan is 3 months. Even with chemo radio, the maximum. Most important is the excruciating pain. She had 3 settings of celiac plexus block, exhausted all injectable antibiotics, and was almost like feeling like committing suicide. But absolutely good quality of life. Though she has to take insulin time and again.